Hi, everyone. My name's Tom Wychowski. I'm an epileptologist at the University of Rochester. I'm going to talk to you today about drug-resistant epilepsy and the alternative approaches to therapy. You might be thinking, alternative to what? Well, we're going to talk a little bit about the role of anti-seizure medications, which is the mainstay of therapy. We're going to define what drug-resistant epilepsy is. We're going to talk about personalized anti-seizure medication therapy, surgical therapy, dietary therapy, and then a little bit about alternative therapies, and I'll explain what that means in a minute. Anti-seizure medications are the mainstay to treatment of patients with epilepsy. About 7 out of 10 people with epilepsy have good, successful control with seizure medications. It's important to understand that some medicines work better for different seizure types or certain epilepsy syndromes. And it's important to recognize that there really should be a personalized approach to choosing an anti-seizure medication based on an individual and their other medical problems and their own personal responses. It's also important to understand that seizure medications work by stopping the seizures, but not by fixing the problem that caused the seizures in the first place. This is information that's now 20 years old. Came from a paper where they followed over 500 patients who were diagnosed with epilepsy, and they looked to see how they would respond to different seizure medications. And so if a patient was diagnosed with epilepsy, they were started on a first seizure medication, and about half of them became seizure-free on that one medication. But for the rest of them, subsequent trials of seizure medications led to diminishing returns. And so for the patients who had to have a second seizure medication, only 13% became seizure-free, while 40% continued to have uncontrolled seizures. And of that group who went on to have a third seizure medication, only 1% became seizure-free with that third medication. And there's always this persistent 40% of patients who would continue to have seizures despite subsequent treatments of medications. So that led us to define something called drug-resistant epilepsy, which is defined as the failure to respond to 2 anti-seizure medications that are dosed adequately, meaning that if someone had a bad reaction to a certain medication, and usually you know that pretty quickly, that doesn't count as a failure. But if they were treated with a seizure medication at doses that we would expect that they would experience a benefit from, but they didn't get that benefit, that counts as one failure. And why did we choose 2? Well, we know that based on studies like this, there are other studies as well that show that a third medication, a fourth medication led to dwindling returns. And so it was important to identify these patients as being particularly resistant. So the term sometimes is used pharmacoresistant or medically intractable. It means that standard therapies just don't work. When that happens, someone with drug-resistant epilepsy should be seeking consultation with an epilepsy specialist. How do you find an epilepsy specialist? Well, there are lots of different ways. Aside from Google, there's the National Association of Epilepsy Centers, which identifies epilepsy centers across the country that are specialized and able to provide a wide range of services for patients with epilepsy. There's also the American Epilepsy Society Find a Doctor search engine, which will show you all the doctors who are registered amongst the largest consortium of epilepsy providers in this country. And there's other ways as well. But this is at the point in which you really should start thinking about talking to someone with expertise in epilepsy. And what might you discuss at an appointment with that provider? Well, first of all is a review of medications, responses, and whether or not there's room to improve or do anything with medications. A lot of patients are told about prospects of epilepsy surgery, and although it's categorized as epilepsy surgery as one big thing, there are a lot of different things that could be considered, at least that I consider as part of an epilepsy surgical evaluation and prospect. There are dietary therapies that have been proven scientifically to be beneficial for patients with epilepsy, and some centers will offer patients that therapy and assistance in pursuing that type of therapy. And it's also important to recognize that clinical trials, when we are developing either new medications, new types of surgery or surgical approaches, new types of diagnostic testing, that is how we get the therapies that we can offer patients that are approved by the FDA is through studies. And so usually at level 4, level 3, level 4 epilepsy centers is where you can participate in clinical trials. And in doing so, you're not necessarily going to be a guinea pig. Patients will often be guaranteed therapy in some regard, and these are therapies that are not yet available to the general population or approved by insurances. So advanced medical therapy, I refer to it. This is a very busy cartoon. I apologize. If it makes you feel any better, this is actually a very, very, very basic understanding of what we do know about anti-seizure medications and how they work. And we refer to this as a mechanism of action. When we talk about how a medicine behaves chemically and biologically in the human body, particularly in the nervous system. And so we have roughly 30 FDA-approved medications, and each one of them work differently. Some of them work in very similar fashions, other work on very, very different ways, and they typically bind to receptors or what we call channels, which are responsible for the transmission of electrical signals in the brain. We think of seizures as being an overexcitation of brain activity. Our brains are electrical in general, and they're always in some sort of state of like a computer being on or off, but they're not completely off. They're always running a program, and a seizure occurs when there's an overexcitation in the circuit board and causes abnormal activity in the brain tissue and therefore in someone's body. And the way in which we try to suppress that is through these various mechanisms, which I won't go into, but it's important to know that each medication either has a specific mechanism of action or even several mechanisms of actions, which we've determined, we found, not we, but the collective epilepsy community through research. And so we know that that's how they work. And it's important to consider those things when deciding what medications are right for a particular person. We know that some seizure medications and their mechanisms are particularly helpful for certain types of seizures, whether it be a myoclonic seizure, which is a jerk, versus a generalized tonic-clonic seizure, which is a convulsive type seizures. Different medicines work in different ways, and seizures tend to respond better to different medicines, as well as different epilepsy types. Oftentimes when I'm seeing a patient for the first time in clinic and I'm obtaining their medication treatment history, I found that maybe they haven't been adequately dosed. The dose of medicine that they've received wasn't adequate, or it could be maximized even more. So quite frankly, there are patients who respond to higher doses of medications than others. They need a little bit more. Sometimes they would respond possibly to combination therapy. So using 2 seizure medications, possibly with different mechanisms of action, which can combat the prevention of seizures differently, will be beneficial to them. If someone has failed a trial of a seizure medication using a specific mechanism of action, it would be potentially advantageous to think that a medicine with a different mechanism of action might have a better effect on controlling their seizures than the first one. And so sometimes you can spare people considerations of things like epilepsy surgery if you just try your best to maximize the medical therapy that they're taking. And the mechanism of action also has a big impact onto adverse effects, side effects that patients might have, and whether or not they can tolerate certain medications. And so it's important to get that information when we meet people. We talk about these medications as we refer to them as maintenance medications. The medications you take every day to prevent seizures. Sometimes you can try the best you can with maintenance medications and seizures are still going to happen, in which case over the last couple of years we've kind of had a renaissance in rescue therapies, strategies in which you can use medications to prevent either clusters of seizures, help stop prolonged seizures, hasten the recovery from seizures if delivered appropriately, and ultimately try to prevent emergency room visits. And so meeting with a patient for the first time might involve developing a seizure rescue plan, which is a very important thing to do, and even determining whether or not a rescue medication, such as the new medications are these intranasal preparations of benzodiazepines versus the tablets that were used before, whether or not they're even a good candidate based on their seizure type for a rescue therapy. But this is stuff that often will be addressed for the first time in an epilepsy center. And then it's very important to promote clinical trials, because All these medications that we're talking about, that I just talked about, are available now because of scientific research that was conducted in order to prove that they're beneficial, that they're efficacious, they help seizures, and that they're safe. And so the only way we're going to get more therapies is for having patients with epilepsy participate in studies like this. So this is the EPI website. I'll plug EPI, and this is a resources tab where they have a lot of excellent resources for patients with epilepsy. And at the very bottom, you'll see a tab for clinical trials, in which case you can follow links to different programs in the area, whether or not it be in Rochester or Syracuse, who are conducting studies or participating in studies to promote these therapies. And if at all you're interested in gaining access to novel therapies or just helping the epilepsy community, I recommend that you seek those out. So moving on to epilepsy surgery, which is usually the first thing that people think about when you have drug-resistant epilepsy. Well, first of all, you need to know who is a candidate. And so typically we think of epilepsy surgery as being for patients who have focal epilepsy. There is really no proven epilepsy surgery at this time. There are things that are being investigated for patients with generalized onset epilepsy or genetic generalized epilepsy, formerly known as idiopathic generalized epilepsy. Focal epilepsy is typically where we thought that there might be a target, an epileptogenic zone that we can identify and possibly direct therapy towards. Someone has to be drug resistant in order to be a surgical candidate. If someone has well-controlled epilepsy on medications, there's no reason to put them at risk for any type of epilepsy surgical testing or surgery itself. We have to be able to find out where the seizures come from in a focal epilepsy in order to find someone as being a candidate for surgery. And at the end of the day, after a lot of testing, we need to determine that the benefits or the potential benefits of surgery outweigh any potential risks. And I'll explain that in a minute. This is a cartoon representation of a brain of someone who has epilepsy, and no one's brain looks like this, but you can see these kind of zones. These are theoretical zones. For someone who has focal epilepsy, we like to think that a seizure starts in a defined area of the brain, whether or not it's because there's scar tissue or something there that doesn't belong there that's causing the seizures to happen, or whether or not it's just an abnormal cells that we can't see on, let's say, an MRI scan. There is theoretically an area in which seizures are generated from, and they can either stay there or they can spread depending on the person. We call this the epileptogenic zone, which is defined as a region. This is based completely on the fact that we're thinking about, can we cure them by removing a zone that they don't need? And if you can, and if you remove that area and someone's completely free of seizures, that is defined as their epileptogenic zone. And this is really the holy grail. This is what we're looking for whenever we're evaluating someone for epilepsy surgery. Is there a defined area that we can safely remove and render someone seizure free? And I wish it was this easy. Epilepsy is more like a network disease. So it's not usually defined to some small area. It usually incorporates cells and circuits that involve larger areas of a brain. But nonetheless, if you can render someone seizure free by taking out this area, then that's what we're looking to do. There are lots of types of epilepsy surgeries, and I'm not going to be able to talk about all of them, but let you know what's in the epilepsy surgeon's toolbox. And classically, we talk about focal resection, where the surgeon can actually remove that area, that region of tissue, assuming it's safe. A lesionectomy is another way to refer this. If there's an abnormal region of brain tissue, whether it be a tumor, whether it be an abnormal blood vessel, whether it be or collection of blood vessels, or whether or not scar tissue, if you can take that out, that is considered a lesionectomy. More recently, for patients whom there's some concern or that you can't reach or safely do a focal resection, there's something called laser interstitial thermal therapy, or LIT, where, and I'll explain this in another slide, a very fine catheter is introduced into the brain and applies thermal heat to kind of cauterize or heat up and destroy tissue in a very controlled fashion. And if you can't resect or you can't ablate, there are a number of neurostimulation devices, which I'll describe a little bit later. There are other procedures as well that can be considered. I won't go into, but just to know that there are lots of different ways in which epilepsy surgery can be employed. The classic way in which epilepsy surgery has been thought of, and the reason why we're thinking about that is the one associated with the most success, is temporal lobe epilepsy and the resection of patients with epilepsy's temporal lobe. So certain patients, there are many patients with epilepsy who have primary involvement of their temporal lobe, which is just an area of the brain that tends to develop seizures in some people. Some people also have scar tissue along the inner aspect of their temporal lobe, called the mesial temporal lobe, and they have hippocampal sclerosis or mesial temporal lobe epilepsy with sclerosis, where we can identify that region, and surgeons can perform an operation that removes that part, the scar tissue, as well as some areas outside, safely, without significant neurologic deficits, and render people seizure free. So this is a hallmark study that was completed in Canada, where patients who had temporal lobe epilepsy with mesial temporal sclerosis were, because it was Canada and not everyone could get surgery at the same time, they were assigned to two groups. One group got surgery right away and were followed over a year. The second group, because they were waiting for surgery, were treated with medical therapy only, with medications, anti-seizure medications, for a period of a year. And what they did was they determined whether or not how their seizures responded. And patients who underwent surgery compared to the medical group had a 58% reduction in their seizures and achievement of seizure freedom, whereas only 8% of the medical group achieved seizure freedom. So it's a significant finding. And this type of finding is what promoted a lot of centers to perform temporal lobe epilepsy surgery early, before patients were failing 3 or 4 or 5 medications, because we knew that they would do better in the long term, as opposed to patients who continue to have seizures while on medical therapy only. And if you look at outside, so the temporal lobe is a common place for patients to have epilepsy. Even if you have other temporal lobe epilepsies, not mesial temporal sclerosis, which is kind of the hallmark temporal lobe epilepsy, or frontal lobe epilepsy, a different region of the brain, if you perform a well thought out and characterized epilepsy surgery, you can achieve seizure freedom in up to half of those patients. Again, this is all compared to patients who would be treated otherwise with additional medications, additional medical trials, where their chance of seizure freedom is less than 10%. If you can do a safe and effective seizure surgery for epilepsy, the chances of outcome are much, much better than medications alone. There's an important distinction, is patients tend to do better if they have an abnormal, what we call lesion, on their MRI scan. So kind of like the temporal lobe epilepsy with the mesial temporal sclerosis, which is the scarring of the inside part of the temporal lobe. You can have lesions anywhere. And in patients who have some sort of abnormality on their, and structural abnormality on their MRI scan, there's some thought that that's most likely where the seizures are coming from. And so if a surgeon were to resect that lesion, as along with any other area that's important in the seizure process, those patients tend to do better than patients who don't have lesions. So if we're determining whether or not someone's a candidate for surgery, what do we need to know? Well, there's two major things. First of all, we need to be very certain that we know what region of the brain the seizures come from. It could be a single region, or maybe even a couple regions. And you can imagine having a single region is better than having more than one region, but that might change what options are available outside of resection alone. And then the second most important thing is, what do these suspected regions do? What are they important for? Are they important for language, memory, body control, movement, or sensation, other important abilities? And typically, we know, or at least we can detect what might be at jeopardy. And we don't want to leave patients with a problem after certain, if their seizures are cured but they can't move, obviously that might be something we would want to avoid. So we need to know all these things before surgery is attempted or considered. The first step to determining whether or not someone is a surgical candidate is to do EEG testing, brainwave testing, while they have seizures, to determine what region of their brain is involved. And this is done in a non-invasive manner. The only thing invasive is that patients will often have to come into the hospital for several days while we watch them have their seizures. Sometimes that type of testing where we're measuring brain waves from the scalp isn't necessarily telling us exactly where a seizure is coming from. Our skulls, there's a lot of tissue that gets in between our brain and where the electrodes are on the outside of our brains. And so sometimes where we suspect the seizures are coming from are deep inside the brain or just not very well recorded on the scalp itself. And so in those cases, we want to again, assure we know where the seizures are coming from, in which case we perform intracranial monitoring where electrodes are surgically placed in areas that are supported by our testing to prove that we know where seizures are coming from. And there are a variety of ways in which these electrodes are placed. I'll go into that in 1 second. Excuse me. There are two major types of electrodes that are used for invasive monitoring, one being subdural electrodes and one being depth. So for subdural electrodes, surgical electrodes are surgically placed right on the surface of the skin or on the surface of the brain underneath the dura, which is the outer covering of the brain. And so, here's that theoretical model where the seizure onset, the epileptogenic zone is. We would put an electrodes or an array of electrodes over the surface so we can pinpoint exactly where the seizures start. And if you're looking at this brain in another section, they would be out here. You can imagine, though, there are some patients whose epilepsy start at regions of the brain deep inside the brain, in which case you're not going to get a very good picture of where the seizures are coming from out here. And sometimes we have to put electrodes into areas that are deep. And so these are called depth electrodes, in which case usually it could be done with with a subdural electrode array, or it can be done independently with just a series of depth electrode. And when we do that, oftentimes there's a series of electrodes that are introduced into someone's brain in multiple regions, and they're done so through stereotactic devices that the neurosurgeon uses. The brain is very secured, and we use a combination of preoperative imaging and software to pinpoint exactly where we want those electrodes to go. And that's so we call that stereo EEG because it's stereotactically placed. And we actually, more so, we have robots. There are surgical robots that help direct the surgeon to put the electrode exactly in the place that we expect it to go, avoiding blood vessels and anything you wouldn't want to put an electrode in. And the accuracy of this is very high. Typically, electrodes are placed and end up within millimeters of where we targeted them to be. The way in which the electrodes are placed are typically, some would consider this minimally invasive. A very small hole is actually introduced through the scalp. And there's with that, there's a less risk of infection. There's less pain associated with this. And patients usually find this to be more comfortable than using the grids where a larger hole needs to be made in the skull and scalp, which can be a little bit less comfortable. So this is how we determine where the seizures come from with a high degree of accuracy. Next, we need to figure out, well, what's the function of the brain around it or in that region? And so there's a variety of tests that we that we incorporate, some of which are non-invasive, such as functional MRI or fMRI, which uses patterns of blood flow to measure function. It's just like any other MRI that someone might have, except that their patients are asked to do tasks, whether it's a speaking task or a movement task, and we can measure where blood flow in the brain is to correspond to what the regions of the brain are responsible for those tasks. There's neuropsychometric testing, which is testing conducted by neuropsychologists, which measures cognitive performance in various domains, whether it be memory, whether it be language. This is it's useful to figure out where someone with epilepsy might have problems before surgery, but then that information can be used to predict what the likelihood of them developing problems after surgery involving a certain region of the brain. Functional mapping is another technique that we use in concert with that invasive monitoring that I just talked about, where we use small currents of electricity delivered through those electrodes to kind of stun regions of brain to determine whether or not, if that region was stunned, does that interrupt normal function of whatever it is we're looking for. There are other things that we no longer use. I won't talk about the WADA test, but these are all ways in which we prior to suggesting surgery, we we use to be able to determine whether or not someone is at risk for developing a deficit after surgery. Let's say a surgeon, or let's say someone is we've determined that there's an epileptogenic zone and we can remove that safely. But let's say that region is really hard for the surgeon to get to because it's deep, or there's some other reason why they're not a good candidate for an open brain surgery and resection. Then we have lit therapy, which I already mentioned earlier, in which a stereotactic guided probe, similar to the stereo EEG, is placed in through a small a small hole in the patient's skull. We use MRI, live MRI, to determine that the electrode's in place, and during the MRI, we can actually measure the heat generated from this. So there's laser energy delivered through this probe, which then is transformed into thermal energy, so essentially burning or cauterizing the tissue in a fairly well circumscribed area, usually in the form of a cylinder. So this is thought to be minimally invasive, mostly because patients do not have to have a large surgery to open up the region of brain, and so the recovery time is much, much faster. I don't consider any brain surgery to be minimally invasive, in my opinion, but this is proven to be very effective for small regions, very small lesions that we determine are epileptogenic. Some centers across the country are using this more in place for temporal lobe epilepsy, and the current data suggests that it's probably less effective than a standard temporal lobe surgery, but nonetheless, it can be effective in up to half of people. For patients in whom a resection or removal of tissue isn't a good option, more recently in the last 10 years, we've been using other means of treating their seizures. Responsive neurostimulation is a system or device that is promoted by NeuroPace, a company, which essentially implants a computer into someone with epilepsy's brain. And electrodes are placed around the area, at the area where we think the seizures start. So you need to know exactly where the seizures start. And what happens is an EEG is constantly being run, and there's detectors that detect seizures. And when a seizure is detected, it causes, in the same electrodes that it was detected, a stimulation that kind of stops the seizure. This is something that we've known for years, that a surgeon can deliver an electrical stimulation, much like a pacemaker to the heart. If the heart goes into an abnormal rhythm, you can shock the heart back into place. This is similar, although you don't need to shock, no one feels the shock, but this has been proven to be beneficial for some patients. It's not necessarily thought of as a means of developing or of getting someone to be seizure free, but there are significant improvement in seizures. At 1 year, the average decrease in seizures was 67% from baseline, up to 82% after 3 years. Some longer term data suggests that the longer that these devices are in, and they tend to, we think, modulate brain activity, the patients tend to have overall improving control of their seizures. There are other stimulator therapies that I call non-targeted stimulation therapies. You don't need to know exactly where the seizures start in order to employ them. One is deep brain stimulation, or DBS, involving stimulation of a part of the brain called the anterior nucleus of the thalamus. This was recently approved in the US in 2018 for adults with uncontrolled focal epilepsy, in which the device is actually implanted largely in the chest, but the stimulator device is in the chest, whereas there's electrodes that are implanted into the brain. And this does not detect seizures. It turns on and off and on and off, and that tends to, we think, modulate brain activity, so much so that 50% of patients have less seizures, and this may improve over time, again, thinking that there's some sort of neuromodulation that happens to improve seizure control overall. Many of you are familiar with the vagal nerve stimulator, which has been around since the 90s, also approved for uncontrolled focal epilepsy in as low as in kids as young as four. And there's more thought that this is something that the benefit accumulates over time the longer the device is in. So I want to talk also shifting from surgical therapies to dietary therapy for epilepsy. Many of you are familiar with the ketogenic diet, either in your research on epilepsy, but also it's a kind of a fad diet where people use it to hopefully get healthier. But it's been known for many, many years, actually, that the ketogenic diet has been beneficial for patients with epilepsy. What is the ketogenic diet? Well, it's a shifting from someone's dietary intake from being what in America is mostly carbohydrates to being high in fat and very limited in carbohydrates and protein. And you have to do mathematical calculations to determine the fat content of all your food. You have to count calories. And it can be very complicated. It requires a multidisciplinary team, including doctors, nurses, advanced practice providers, dietitians, pharmacists, and social workers. This is what a typical American diet looks like if you just compile the ratios. It's more than half carbohydrates, a lot of fat, and a little bit of protein. Ketogenic diet is all fat, or mostly fat. The 4-to-1 diet is 4 parts fat to 1 part carbs and protein, very little carbs. And what does this do? Well, the ketogenic diet, the standard diet, everyone processes mostly carbohydrates into to generate glucose, which is kind of the primary fuel source for the whole body, including the brain. When you don't have carbohydrates, you don't have glucose. Essentially, what your body then does is it shunts fuel production to ketones, which is an alternative fuel, one that's actually pretty good for the brain. And for reasons that are not quite understood, this produces seizures in patients with epilepsy. I won't even go into what the proposed mechanisms of those are. But in many, many studies, it's been proven to be beneficial and reduce seizures significantly. In the early 2000s, the modified Atkins diet was developed at Johns Hopkins, during which there's a little bit more flexibility in the carbohydrate restriction. So there's some carbohydrates that are allowed, and it can be done at home. The important thing that I will go into is that there's results. And so specifically for modified Atkins in kids, there's 65% of kids had a greater than 50% seizure reduction at 6 months. And other studies have shown similar results. Between 40 and 60% of patients can experience a significant reduction in their seizures. The same kind of goes for adults, although the responder rate, which is the number of patients that achieved 50% reduction in their seizures, was somewhere around 30 to 40% or so. Obviously, there's limitations in dietary therapy. It's very hard to stick to. And that's why centers like at University of Rochester, we have an outpatient clinic, and the adult side, it's head by Dr. Banu, who I think gave me the slides for these, and then Dr. Ina Hughes on the pediatric side. And then real briefly, we're talking about alternative therapies, since technically that's the title of this talk. We consider alternative therapies to be different from conventional therapies, which are those that doctors and mainstream health professionals prescribe and promote. Alternative means they're completely different, means that the only thing that that a patient tends to do is use that alternate therapy, whereas complementary therapy is used when you tend to use these alternative therapies along with conventional therapy. The limitations with, at least at being a conventional provider, I would have to say, is advising patients on what to do about these, is there's not a lot of data that support whether or not they work. Many alternative therapies have not been studied using strong scientific approach. So therefore, we don't know how well they work. We don't know who they work best for. We don't know what the risks of therapy are. There's a chance they might not work at all. But in my experience with patients, and I think anybody would agree, is whatever they are, they probably do something. You're introducing a foreign substance into your body, regardless of whether or not it's FDA approved and available at Walgreens or whether or not it's coming from someone's backyard. They're doing something. We just don't know what that is. And so, I use medical cannabis is actually a good example of this. Some people consider it an alternative therapy. I just considered it when it was, particularly gaining steam over the last 8 years or so. It wasn't so much that it wasn't doing anything. It was doing something. We just didn't know what it was doing. And it has effects. I mean, there's no question that cannabis has effects on the human body. But through scientific research, we learned, and we still have a lot to learn, is that it's cannabidiol, which is a compound that we think has some impact on epileptic seizures. Whereas THC, the psychoactive component of cannabis, really hasn't been shown to have any benefit as it pertains to epileptic seizure control itself. And so when I have patients who are considering alternative therapy, I welcome that. I usually ask them to run it by me. I'd rather know, because in addition to having effects on the body in terms of benefit or treatment, they also have interactions with medications that can cause liver damage and whatnot. And so I ask that either they refer to these resources. The National Center for Complementary and Integrative Medicine through the NIH is a database for all these types of alternative therapies, and it lists all the information we know about it. Here's another resource that I tend to use, which is Natural Medicines, or just ask your provider, and we'll be happy to look it up and offer some advice. That's all I have, and I'm looking forward to some questions and answers.
And look at that, Dr. Wychowski is on with us. How about that? That was really good. Thank you so very much, Dr. Wychowski. I emailed you, but we had a little technical difficulties at the beginning. For some reason, about a minute in, the presentation just stopped, but we restarted, and I think we made it. So I'm going to open it up for you guys to answer or ask any questions of Dr. Wychowski. I can actually start us off. I was really intrigued with the probes that neurosurgeons use to get right into the center and combat the seizures that are happening. How resilient, Dr. Wychowski, is the brain when you insert a probe or the thermal fusion, basically, into the brain? Like, how often? What is the risk of these side effects of long-term side effects of having that happen in the brain?
That's a great question. And it's one of the reasons why, and I didn't have time to go into this. Sorry about the speed of my rate of speaking. There's a lot of stuff I try to cover in a confined amount of time, but this whole concept of doing invasive either EEG monitoring or now more, even the therapies where it involves inserting probes into the brain, although it's probably in the last 5 to 10 years been more common practice in the United States. It hadn't been before that, but the French have been doing it for decades. I have a picture of a black and white photo of one of the earlier patients, and it's clearly from the 1960s. So the reason why I think it hadn't been adopted in the United States is because of what you're probably we're getting at is, can we put electrodes into the human brain and not expect to cause some damage? And through years of experience, the thought is that it really is actually not that unsafe. Modern technology, first of all, when we do, and I didn't go into this at all, when we plan for one of these procedures, we do a lot of imaging, and many of you have probably seen modern MRI scans. They give very detailed pictures. We include something called angiograms, which is pictures of blood vessels. The software that we use and that robot that helps direct where the electrodes go allow for exquisite precision in where our electrodes end up, more so than even the techniques we were using, in the United States a couple of years ago, where surgeons have to open up the region to expose the brain and then just blindly kind of slide electrodes places safely, but you don't know where they really go. And so in terms of risks of bleeding and infection and brain swelling, they're actually significantly less than invasive monitoring that we still do sometimes, but we're doing less of these days, the grids, and we call them grids and strips, because there's less exposure of the brain to the environment. You don't have to do as wide of an opening. Some surgeons refer to it as minimally invasive. I don't think that exists in neurology in general. Anytime you're putting something in the brain that's invasive, and it's not minimal. In terms of the brain itself, they have, done studies to look at the brain afterwards. And it's No, it's impossible to put an electrode, even as fine as it is. To give you an example, it's probably, I've got this charging wire here. It's probably thinner than your charger on your phone. It's much thinner. It's almost, and it's very flexible. It does make a little tract, but as far as we know, there have been no cases of those tracts causing someone to have epilepsy. And we usually avoid bleeding and things like that. And the procedure, the stereo EEG procedure, when patients, they have that implantation completed and they come back up to the floor, because then we want to see their seizures and record the activity off of the wires. And the patients who have that procedure are very, their pain is under great control. They're almost normal by the first day afterwards. There's a little bit of pain, whereas the other procedure, there's usually much more lingering pain. We have to treat it and make sure everyone's happy and healthy. But for that reason, it's not as bad as you would think it would be. Now, the other thing you referred to is the laser interstitial thermal therapy. That's something that is a little bit more involved. Obviously, that the goal of that therapy is to cause brain damage. It's just a very controlled brain damage. It's thought to be similar to when a surgeon takes a scalpel and cuts out that part of the brain. It's just, you don't have to open up, expose, and use a scalpel. You use this very precisely engaged, wire that delivers the lesion that you're looking for. It's been proven to be safe. And for a bunch of reasons I won't go into, but the brain is fairly resilient in that regard. The bigger issue with that is whether or not that approach is as effective as the standard approach. And it probably isn't necessarily, but it does work for some people. And because it's less invasive, some centers, they will go to that first. So.
All right. Thank you very much. Amanda, I see you have your hand up.
Yeah, I'm just wondering if you're aware of any studies where so patients with drug-resistant epilepsy that have tried multiple different seizure medication combinations and aren't candidates for surgery, are there any studies as far as when they come off a medication and their seizure frequency? Because like with my son, I've noticed more seizures or different types of seizures as like introducing another medication. So in my opinion, like the medication has worsened his seizures, some of them, but more than that, it's like the side effects of the medication make his quality of life so bad that I just wonder, without medication at all, are there studies on that?
There's, as far as I know, actively. So that, first of all, it's a really hard thing to study because, number one, I would argue it happens, and I've had patients and that exactly happens. A medicine that you think is going to work makes someone's seizures worse. And it's not common, but it does happen. Because it's not common, it's really hard to study, and it's hard to scientifically. And when you do study something scientifically, you have to be able to measure it in a standard way across different people. And so that's a difficult thing. It does, though, remind me, there was a study done, this was the 80s, I think, by Penry, who was really he was actually one of the developers of Depakote, which is an older medicine now, we consider it, but at the time it was a kind of a landmark medication. But anyway, he did some studies to take patients who had really intractable epilepsy and were taking 4 or 5 medications and measure their response, both in seizures and their quality of life, after taking them off their medicines. And they actually found that they were patients benefited oftentimes. And sometimes these were patients who had intellectual disabilities, cerebral palsy, and things like that, who just kept on getting more and more medicines because the seizures were not responding. And you do reach a point where too many medicines has the opposite effect, a paradoxical effect. And so, that is the only study I'm aware of that actually studied that and proved that. And it's influenced what I do in terms of when I see patients. If we work with medications, I'm not a big fan of adding, once someone's on 3 medicines, I really have to have a strong reason to try a 4th without at least getting one out of the way, because too many medicines can be even, harmful for people. So.
Thank you.
No problem.
Ellen, you have your hand up.
Yes, thank you. I was wondering if there are any reasons to have neuropsychometric testing other than surgery. If you're not having surgery, are there reasons to have NPT?
Absolutely. Yeah, there is. And we use it more. That was just because we're talking about it. I was using it as an example of how we, work up a patient for surgery. It's very important, but absolutely, because we know that epilepsy, or patients with epilepsy, are at high risk of having a lot of cognitive issues, whether it be memory problems, language problems, even just, and I say that broadly because there's subdomains of all those fields. And so, yeah, absolutely. We know that medications can impair those things as well. And so if I have patients who, have trouble enough functioning because of seizures, having trouble functioning because of the cognitive decline that they're suffering because of it, you need to quantify that. And for those of you who've ever met with a neurologist in the office, there's only so many things we can do, to test someone's brain. Obviously we can do the finger pointing and then shining lights in places, but to actually get at what is causing their cognitive issues, you have to refer them to a neuropsychologist and get that formal testing done. That's why we have a neuropsychologist at our center, and they're always happy to see patients with epilepsy and any cognitive deficit that we want to kind of quantify and understand better. So, and that's something often will trend over time as well, because whether or not you're doing surgery or doing any other kind of therapy, it's important to know how well someone's doing in any of those domains over time. So.
Okay, thank you. Could I ask also another question while I'm here, Mike?
Yeah, Ellen, why don't you ask the question you put in the chat?
Oh, yes. Okay. So one goal that you stated was of hasten recovery after a seizure. And so I was wondering what can be used to do that?
Yeah, so that's tricky. It depends. And that was specifically with regard to rescue therapies. It's very tricky, which is why I should probably emphasize the thing I had at the bottom of the slide is number 1, which was first to develop a seizure rescue plan and determine whether or not those medicines are appropriate. Those medicines are sedatives, and so if they're sedatives, but they're also very effective seizure abortive medications.
Mm-hmm.
If someone were to have a long seizure or a long warning, such that you have time to recognize it and act, you might be able to use a medicine as long as it's appropriately administered. So the tablets usually aren't good enough for that, but the nasal sprays, and there's other products in development that can act within seconds to minutes. You could stop that seizure and then prevent it from progressing to a bigger seizure where you will need to recover. That's the only way in which I can think of that you can hasten recovery. You still might be, some of that will depend on how long it takes someone to recover from a seizure in the natural state. But those medicines can be sedating. They can knock people from a loop. So if you have a seizure and you take a medicine right after the first one, you might actually have a longer recovery. So that's kind of a soft reason to think about seizure rescue medicine. But there's a medicine in currently in development that we're doing a clinical trial on. That's an inhaled version of one of those medicines. And the reason why it's a little bit innovative is all the other medicines are meant to stop clusters of seizures. So people who have one seizure and then another one really quickly and another one really quickly, we call that acute repetitive seizures. And anything that's on the market right now is actually meant to stop a next seizure, a second, a third, or fourth seizure. This medicine that they're working on with an inhaler, it's meant to stop a seizure the first time when it happens. And the thought would be is that might be beneficial with recovery and preventing a progression from a small seizure to a big seizure. It's really hard to do, and it's hard to time sometimes.
Okay, good. When is that coming out?
We need to get people to participate in the research. So it is in phase 3 studies right now, which is usually the study that's needed to get it formally approved by the FDA once it is available. And if you're interested, you can reach out. I think if that link that I put on the website, that's how you can get a hold of our study coordinators at our institution. You have to, the tricky part is for that study, someone has to have long seizures and they have to be fairly frequent enough to test whether or not the medicine works, which is easier said than done for some people. Obviously, when these medicines get approved, then people can use them a little bit off label and they can be used more generously. But in order to qualify for the study, you have to have very specific type of seizure, which we'd be happy to screen anybody if they're interested. So Mike can actually put people in touch with me if you want, or if you want.
Go to epiny.org under the epilepsy tab, and it's listed down in there under resources.
Okay, thank you very much.
No problem. Good
Somebody
questions.
else? Does anybody else have anything? Any questions? Well, I, for one, again, I learn so much every time I'm on these calls. But thank you so much, very, very, very much, Dr. Wychowski, for sharing and spending the time doing the pre-recording and dealing with me through all my crazy emails. But I appreciate it. And don't forget, everybody, we have a few events coming up. We have our snow tubing tomorrow in Rochester. We have support groups, of course, and our chocolate ball is coming up at the end of April. So hopefully everyone would like to experience some good, yummy chocolate and raise some money for EPI. So with that being said, it's now 7:01, and I appreciate all your time, and we'll talk to you guys soon. Next month, same bat channel. Dr. Bono is going to talk about a whole lot about EEGs and stuff like that. So we're looking forward to that. So thank you again. Thanks, Dr. Wychowski, and thanks all of you for jumping on.
My
Thank you.
pleasure. Have a good evening, everyone.
Thank you.
Thank you so much.
Thank you.